Okay, we will go ahead and get started. Good afternoon, everyone, and good morning to those joining us from the West Coast. My name is Hamara Osman, and on behalf of Muscular Dystrophy Canada, I'm very happy to welcome you to our webinar from our new Let's Talk NMD, Let's Talk Neuromuscular Disorder series. Before I introduce today's topic, I would like to mention that we have muted all participants, but I welcome you to type any questions or comments throughout today's session in the chat box. We have allotted time at the end of today's webinar for a live Q&A. Today's weekly webinar is on adults living with spinal muscular atrophy, SMA. This is a very timely webinar as August is Spinal Muscular Atrophy Awareness Month here in Canada. This is a month dedicated to increasing awareness for SMA, supporting those living with SMA, and creating connections for the SMA community. Last week, we had an excellent and informative webinar on what is SMA, what treatments are available, and what is the status of current treatments and research for SMA in Canada. That webinar recording is available on our MDC YouTube page. As mentioned, today's webinar is specific to adults living with SMA, and we're very grateful for our fantastic lineup of speakers that can help to share trusted and evidence-based information on SMA. In advance of their presentations, I would like to thank each of our speakers for their time and expertise. First, we have Dr. Tim Hagenacker from Germany. He received his medical degree in 2007 at the University of Duisburg-Essen in Germany. His doctoral thesis focused on modulation of voltage-gated calcium channels and interactions with thermus receptors and sensory neurons. Since 2009, he works as a postdoctoral scientist and clinician in the Neuroscience Lab, Department of Neurology, as a group leader of the research group Diseases of Peripheral Nervous System. Together with this group, he recently published a paper titled Nusinersen in Adults with 5Q Spinal Muscular Atrophy, a non-interventional multi-center observational cohort study. We're very grateful to have you today. I'll go ahead and stop sharing my screen so you can upload your slides.
So I'm glad to be invited to your meeting, and today I want to talk about especially on or about the care of adult SMA patients, and I want to give an overview of the current medical treatment options we have now as we have possibly in the future. A first and very important message is that some things never change in the care of SMA, and that is the multidisciplinary team we need for management and care of especially adult SMA. We will further have need for the general practitioner, the neurologist or pediatric neurologist, for nursing care, for pulmonary and orthopedic care, also genetic counseling and nutritionists. This is what we have in the past, and this is what we still need in the future, even if the medical treatment options are getting better. The role of the neurologist or the pediatric neurologist in this field has been changed. So in the past, the neurologist or the pediatric neurologist was mostly for the organization, the one who gets all the information, combines the information, and send the patients to the specialist their need. But with the current treatment options and especially with the future treatment options, we are going over to a more active role, so that even the neurologist is a real treater of the disease. And this is the picture what undergoes an ongoing process of change. And this change is accompanied especially by the adult neurologist, that our feeling about SMA and our observation of SMA has changed, because in the past, we mostly thought that SMA, when patients reach adulthood, was a stable disease. But we were more and more aware that the natural history of the adult SMA part is still a progressive disease across all SMA subtypes. And there are two major publications that give a little overview of that. Especially the problem is that the SMA caused during childhood. It is very well described by several manuscripts, but there is a data gap when patients reach adulthood, and there is only less information about that, but there is some information, and that is in line with our personal feelings and our own observation that patients experience a progressive decline in their strengths especially of the extremities, and this is what you see on the left side. Here is some kind of sum score when you add all disease of strengths together. You see that with ongoing years there is a progressive decline even when patients reach adulthood. It is still progressive, and and also in functioning in motor function, there is also a decline by estimated on that so-called Hammersmith score. Possibly some of you are familiar with that score, that there is a decline in that score. When you have full ability, you have 66 points on that scale, but you see that still after reaching adulthood, patients are getting worse. And this is one of the rationales we see nowadays, that treatment can also start when patients are still are already adults. And this is accompanied by some other rationales for treating older patients with SMA. Beside the experienced progressive loss of motor function, the residual motor function is absolutely necessary for patients to be in social integration, to be in employment and so things. So this is mainly dependent on the residual motor function, and this is another rationale for treating older patients. When looking at the more severely affected patients with only a very severe and also already progressed disease, the function of the respiratory, the pulmonary function is also a very important point, which need to be addressed by medical treatment options. And we are aware of the positive data we have, especially from the Nusinersen or the risdiplam treatment, that we know that these are effective drugs during infancy and during childhood when treatment is initiated there. Our therapeutic goals are stabilization of disease progression, or if possible, some kind of motor improvement. But now we know that this depends on the prior motor function before initiating a treatment, that we see that stabilization even in the very severely affected patients when looking at respiratory and pulmonary function, and that our therapeutic goal, that this should be finally improve their social and patients' independency, and this should improve also the quality of life of patients and their caregivers. And with that, I want to give you an overview of the current medical treatment options we have now. On this slide, I summed it up, the current medical treatment options at a glance. So Nusinersen or Spinraza, this is the drug which we have the most experience for now, more than 3 years of treatment. It has an approval for all SMA types, age and conditions, but reimbursement is very varying from country to country. There is no controlled data in adult patients, but we have now some real-world studies. Our own study has already been mentioned. It has to be injected into the lumbar spine, but in complicated spines, which is a typical problem in adult SMA patients, we need the radiologist for example, computer tomography guided injection procedure. And each computer tomography or other radiologic procedures are typically accompanied by the risk of radiation, and therefore by the risk of radiation exposure, and therefore by increased risk for cancer during lifetime, for example. Risdiplam is also a drug which can be used for the treatment of SMA. It has yet been approved by the FDA for, I think, for 10 days. It gets the FDA approval for all SMA subtypes. In Europe, the approval process is still ongoing. The most advantage against Nusinersen is that this is an oral medication, so you have to be managed with that injection procedures or with computer tomography, for example. And we also have controlled studies, but these studies, in contrast to the Nusinersen studies, already include some experience with adult patients. All of these patients were non-ambulatory and they were less than 25 years, but there are some patients that have that age, and we have controlled data about the efficacy of risdiplam in such a patient cohort. And we have Zolgensma, the real name of the drug, I can't even spell it. It has been approved for the treatment of less than the second life year. In Europe, our approval, we can treat independent of age, all patients with SMA type 1 and type 2. So there is no limitation by age, but there is only safety data for a body weight of less than 13.5 kilogram of body weight. And the most advantage is that it is only a single infusion of the drug, but the safety profile is not that good as we see it in Nusinersen and risdiplam. So these are the current or a little bit future has just reached the current date. The medical treatment options we have now, and this is an overview, and with that basic information, I want to give some insights in the drugs point by point. So this is the profile of Nusinersen. As already mentioned, it has to be injected into the lumbar spine. In the first year, it has to be injected 6 times, and then you need a repeated injection 3 times per year for a maintenance phase. Serious adverse events are rare. There is some kind of hydrocephalus which has to be observed in some patients, but is a very rare adverse event in comparing the number of adverse events with the number of treated patients. I think there are now more than 5,000 patients that have been treated with Nusinersen. The adverse events that typically occur are lower back pain or headache, but these adverse events are not from the drug itself. It is more from the procedure of lumbar puncture. The FDA approval was in 2016. In Europe, we were able to start in 2017. So we have now a very good experience using that drug, and there were 2 pivotal studies, but both studies doesn't include adult patients. And these, I want to give only a minority of some numbers, but there were three major studies that were essential: the so-called nurture studies, the ENDEAR study, and the CHERISH study. And for efficacy, especially for SMA type 1 and type 2, ENDEAR and CHERISH study was the milestone studies. ENDEAR study was focused on SMA type 1 patients. When patients entered that study, they were less than 7 months. And in the CHERISH study, this was more focused on the SMA type 2 patients, and patients were included from year 2 to 12. Here in the results part, you see that the SMA 1 cohort in the ENDEAR study, that in the that 0% of the placebo group has reached a motor milestone against 50% that reached motor milestones, and this was a very good result, that so many patients are getting better when using that drug. and looking at the SMA type 2 patient. This was more focused on the motor function using the Hammersmith scale I already mentioned. And in the group of patients that received Nusinersen, they improved by around 4 points from that 66-point scale, while the sham control group loses 1 point. And additional information is that a change of 3 points or more is clinically, as we say, meaningful for the patients. So more than 3 points can be really felt in activities of daily living. But as already mentioned, and as you see, there is a major data gap when reaching the year of more than 12, and especially in the adult populations. And we have several patients in their 30s or 40s. There were no data on that, but in Germany, we have the advantage that by approval, we get reimbursement for the drug, so we can use the drug. This is very different to many other countries in which approval is not in line with reimbursement by the health insurance company. So we had the option to combine our data in the study that has already been mentioned and finally published this year. And in our study, we were able to include more than 150 all adult SMA patients, including all SMA types. And we combined the data of 10 neuromuscular centers in Germany. Essen is here in the west of Germany, and we were able to include more than 50 patients in our study. And we looked at the same outcome parameters like the clinical studies do, which is the Hammersmith scale, the so-called Rulm scale, which focuses more on the upper extremity, so more on the arm function than the Hammersmith scale does, and the so-called 6-minute walk test, which is a test which measures which distance you can walk within 6 minutes. So this is for the ambulatory patients to get a feeling if there is also an improvement. And I don't want to confuse you with the very high number of points and scales, but just want to give you a short impression. I mentioned that you need 3 points or more that you can feel an improvement. And after 6 months, we found that there was an improvement of 1.7 of 66 point on that scale. After 10 months, there was an improvement of 2.6 points on that scale. And then after 14 months, we reach the magic number of more than 3 points on that scale. And this was also been found in the upper extremity function. You see here 0.6, 0.6, and then more than 1 point. And the walking distance in the patients that were ambulatory also increases by finally more than 46 meters. And 46 meters may be very essential for someone who has a prior motor function status that can who can only walk 5 or 4 meters. It is a massive increase in one's radius. So this may be very essential in the light of quality of life and being independent from others. So to compare our data with the data we have in children, we looked and when we compare that, here you see the data from the CHERISH study, and you see that there is an improvement of approximately 4 points. And here you see our study in the adult patient population with more than 3 points. So you see that there is only a difference between adult patients and patients during childhood of approximately 1 point. So we were able with that study to give evidence that Nusinersen is also efficacy in adult patients, and I hope and I'm aware that it has that our study has changed the landscape of treatment options, that with that data, Nusinersen will be available in several other countries in which reimbursement for adult patients does not exist yet. So we think that this study, yes, we have enough evidence to underline the efficacy of the drug even in adult patients. But I mentioned some managing problems, some challenges, and this is a little bit the twist within. And in contrast to the to infants or children, especially the adult populations, we have the problem that we have to deal with complex spinal situation with so-called scoliosis. So there is a twist in the spine, or on the other hand, prior surgical procedures, the so-called spinal fixation or spondylolisthesis has been implanted during childhood. And then we have the problem that we cannot reach the spinal room with a lumbar puncture needle without using CT guidance. And when Nusinersen has been approved, many centers thought that that we cannot reach the spinal level in these patients, and they also, therefore some centers didn't start with treatment. But we ask our neuroradiologists if they see if there is an option when using CT guidance or other radiologic procedures. And as you see, this is the needle here, and it's going from the back and just between that spinal fixation, reaching here the spinal space where the drug has to be injected. And with that, we think that this is an option for situation with complex spines. And we also published some data on that. This is some very early data. As you see at that time point, we had included 28 adult patients, and using the CT scanner, we were able to inject the drug with more than 6 injections in more than 90% in the patients. But 90 or 97% are not 100%. So what about the minority of patients in which we weren't able to inject the drug? So another treatment option, I have to mention that this is possibly an off-label use depending on the FDA or the European label of the drug. And we had some cases in which we implanted a spinal catheter in the abdominal side, connected to a very small tube with a very small inner diameter, and this tube is implanted by a surgical procedure, and then the drug is injected at the abdominal side of the belly. There is, you can implant such a device, and here is some kind of membrane, and you can feel that membrane with your fingers under the skin, and there you can inject the Nusinersen, and then you reach also the lumbar space. But this hasn't been used very frequently because, as already mentioned, in the majority of patients we were able to inject it using CT guidance, because that lumbar port is possibly accompanied by problems with local infections, or if a catheter is getting stuck, then you won't be able to inject the drug further. So it is only for a minority of patients, but it is a treatment alternative in those in which we won't be able to inject it using CT guidance. But the CT or fluoroscopy guided procedure is, as already mentioned, accompanied by radiation exposure. And as already mentioned, the drug has to be injected 3 times a year. So with ongoing years, you have more radiation exposure, and therefore the possible risk with increased risk of cancer during life. But we see that with ongoing experience and with ongoing number of injections, you see that the effective dose, dose is measured in millisievert, and we need initially 3 millisievert, and 3 millisievert is some kind, if you fly 30 times from Europe to USA or to Canada, then then you have the same dose of radiation like one CT guided procedure, but with ongoing treatment, you see that there is a decline in the dose we need, and that dose is especially higher in the patients with a spinal fixation or spondylolisthesis than in patients that haven't a spondylolisthesis. So radiation exposure is a problem we have to deal with, and patients have to be aware of that. So we think that Nusinersen, possibly in such complicated spines or spinal situation, we need drug alternatives, and this is possibly where risdiplam from Roche comes into the treatment landscape. As already mentioned, the major advantage is that this is an oral compound. It is a liquid, and it will have some strawberry flavor, as I know, and it can be self-administered. It has to be administered daily. Serious adverse events are very rare. There is only the hypothetical problem of problems with vision, because we know from animal experiments and from similar drugs that in excessive high doses there may be a problem with the optical nerve, but this hasn't been observed in the clinical studies. And normal adverse events are also rare, and with the data on efficacy we have, the drug gets its approval only a few days ago by the FDA. And there were also 2 pivotal studies. These are the so-called FISH study. There is a FIREFISH study which observes the efficacy in SMA type 1, and the SUNFISH study that looks at older SMA type 2 and 3 patients. And in that SUNFISH study, also adult patients has been included, but yet we have no experience in the real world. This is just data from the clinical studies. And here I want to give you only some facts about the SUNFISH study. In the SUNFISH study, not the Hammersmith scale was used, but another functional measurement scale was used. And in that population, patients were included from 2 to 25 years. And here in orange, you see that improvement of motor function by the drug in the patient group that received risdiplam, while the placebo group after 1 year remained stable, but they doesn't improve during the study time. But there is some data on the age groups. We have data on 2 to 5 years, 6 to 11 years, 12 and 17 years. And in gray, there is a placebo group, and in orange, there is the risdiplam group. And in most groups, you see that the orange bar is higher than the gray bar. So in these patients, we see a higher amount of patients that have a relative change of more than 3 points. So here the left bars are very interesting, but with ongoing years you see that the number of patients that reach that meaningful 3 points level is going back. And in the group of 18 to 25 years, this is adult cohort, patients remain stable, which is also an important goal, but the number of patients that are getting or experience improvement in motor function is only a minority. But I have to add that this group of patients is very small. These are, to my knowledge, only 8 or maximum 10 patients of that group of 18 to 25 years old patients. And all of these patients are wheelchair dependent for a long time. So very severely affected patients has been treated in that group. And we know from the Nusinersen trial and from our own Nusinersen data that the improvement that I mentioned is mostly driven in patients that are in good motor function status, especially in those patients who were still able to walk. So we don't know which drug is better. There is more an advantage from the procedure side. And finally, there is Zolgensma, in contrast to the other drugs, which more use the SMN2 gene, which is some kind of our own replacement gene, and the drugs are working there. In contrast to that, Zolgensma is a real gene replacement. So in an encapsulated virus, an adenovirus, which can mention some common cold diseases, that virus is used to integrate the missing genetic information into the neurons. And because neurons are they are there for their lifetime, because neuronal cells they don't divide further. When you infected with that virus all neuronal cells, you have possibly that genetic information in these cells for a very long time, and therefore only a single infusion of Zolgensma is needed. But Zolgensma is a virus, and it is an infusion with a virus, and every virus activates our immune system and tries to defend against that virus. And that's the reason why our immune system makes some problems. So there are, in some cases, very serious adverse events when using that drug, with some kind of liver toxicity, so-called autoimmune hepatitis, which can lead to a possible liver failure, which can be very harmful. But the drug gets its approval for treatment within the first 2 years. The Europe label has an approval for type 1 and 2 patients, but we are limited by, as already mentioned, by body weight, because we have only safety data for body weight of less than 13.5 kilograms. So we think that this is currently not an option for treating adult patients, especially while most of the adult population have already preformed antibodies against the virus that the drugs uses, because as mentioned, it is a virus that is responsible for a common cold, and the older you are, the more viral contact you have. And if you have that preformed antibodies, then the body defends and terminates that virus, and then our immune system destroys the Zolgensma, and we think that we don't have an effect in that. And we don't know the duration of the effect. We think that Zolgensma is possibly active for 5 or 7 years. So Zolgensma, possibly after Zolgensma treatment, we will then need other treatment options. So it is possible to combine Zolgensma with other drugs, but on that drug combination, there is no data on that. There are only a few cases in which that treatment option has been used. So to sum that up, simply the best, which drug for which patient. So I have to be honest, we have no data which compares the drugs to each other, but that would be helpful information to give answer to that question. So we currently don't know which drug is the most efficacious drug of all, but we suggest treatment in all progressive, and most of the adult patients are progressive, as we see it by the natural history. So we think that most of the patients should be on treatment. The treatment goal depends on the prior motor situation. So stabilization should be the minimum treatment goal in all patients, but the better the patient are when initiating a treatment, the more probable is that that patients undergo an improvement of motor function. So we think that treatments should be initiated as early as possible in adult patients. We have the most experience with Nusinersen, but with the upcoming or recently approved drugs, we can choose and we can design the treatment options to the patient's personal situation in complex spine, for example, or if the drug application with Nusinersen is possibly not feasible, then risdiplam can be the first option. But Zolgensma, I think in the intravenous formulation, it is not a real good candidate for treatment of adult patients, but there are other studies that focus on inject Zolgensma directly into the lumbar space, like we do in Nusinersen, and then you need much less virus, and then it can be possible a treatment option for adult patients too. And this is my slide from the start. I just want to remind on the multidisciplinary management team we need for SMA care, and that this team is not replaced by any medication. So combining the medical treatment options with the multidisciplinary team should be the current state-of-the-art treatment of adult SMA. And with that, I want to give just you a short impression of our city here, which has a long tradition in history, but nowadays this is also history and is more now a very known museum, and is approved by the UNESCO as World Legacy. Thank you for your attention.
Thank you so much. That was a very good and comprehensive review. As you go ahead and stop sharing your slides, Dr. Pfeffer will share his slides. We next have Dr. Pfeffer, who is a clinician scientist in the Department of Clinical Neurosciences and Hotchkiss Brain Institute at the University of Calgary. He completed his medical school training at McGill University Neurology Residency at the University of British Columbia and PhD training at Newcastle University in the United Kingdom. His research focuses on gene discovery in hereditary neuromuscular diseases and mechanistic processes which cause disease pathology. Dr. Pfeffer has also recently contributed to a letter to the government that was published most recently in the Canadian Journal of Neurological Sciences, and we're very grateful to have him here.
Thank you very much for that kind introduction, and thank you for inviting me to speak on this topic today. I am going to talk about treatment and monitoring of SMA in adults in Canada and try to complement what we've heard in Dr. Hagenacker's really excellent presentation. I'll start by mentioning that I don't have any competing interests to disclose, and we'll give you a little outline of what I will speak about today. Mainly, I would just like to outline some Canada-specific challenges, as well as some general challenges for SMA treatment and monitoring in adults. We're in a unique situation in Canada where health is governed provincially, and as a result, we do have some provincial variation in access to treatments, and I'll speak a little bit about that as well. My goal for this presentation is to make it accessible to persons impacted by SMA, but if anything is unclear, I'm happy to answer questions at the end. Just as a very brief review, we generally divide up SMA into a number of different clinical types. There is some historical variation in how these groups are defined, but in general, these are in decreasing order of severity and with increasing age of onset. So the most severe cases will be type 1 starting in very early infancy, and the type 4 cases, for example, will start in adulthood and will generally keep their ability to walk, or in other words, remain ambulant. Now, some of these clinical types do proceed to adulthood. Type 4 typically presents in adulthood, and patients who have type 2 and 3 will eventually go on to become adults and then encounter some of the issues that we're going to discuss. And type 1 patients historically have not survived to adulthood, although with the recent development of treatments for this condition, we of course hope to see that change and hope to eventually see type 1 patients surviving and living well into adulthood. The key points I wanted to make about this when looking over that slide is that adults with SMA does make up a very heterogeneous group. You have patients who had their onset as very young infants who will accumulate a lot of weakness and may have difficulties even with sitting. And this includes a large spectrum that includes people who will have developed their symptoms only in adulthood and will have relatively milder weakness that may impact some of their general life activities, but otherwise still allow them to walk and continue with most activities. As a result of this, our monitoring has to be different for different adults with SMA because of this broad variability. And it's quite possible that treatment effects may differ. And of course, as Dr. Hagenacker had pointed out, we don't have a lot of evidence really demonstrating what the treatment effects are in adults at this point. SMA management is multidisciplinary. This is a slide that is similar to the one shown in the previous presentation. Only a small piece of this is medication. Of course, there's involvement of a number of health professionals, and within our neuromuscular rehabilitation group are our allied health colleagues in physiotherapy and occupational therapy. The use of medication in this condition has its own implications for the management of patients, who is eligible for treatment, and how we proceed with the clinical monitoring of the condition. Just to very briefly summarize medical therapy that's available for SMA, this was covered in the last presentation. Only Nusinersen is currently approved for use in Canada. This was approved in 2017 for children. And later on, there was approval or funding rather that was made available for adults. It was something of a peculiar situation with the approval of Nusinersen because at the time of its approval, it was approved for adults with SMA, but there wasn't actually evidence for adults at that time. As pointed out earlier, the trials that were done for SMA were done in infants and then eventually in children up to the age of 12. Eventually, there was funding that was made available for adults. And I just wanted to point out that Nusinersen and Risdiplam are the ones available for adults. Now, eventually, provinces and territories in Canada have decided to make funding available to treat adult patients with Nusinersen. Quebec was the first to do this, and I believe that was at the end of 2018. And based on their early guidance, their intention was to approve this fairly broadly for adults who had SMA types 2 or 3, but not type 4 as far as I'm aware. In other provinces, this was gradually approved as well for funding in adults based on case-by-case review. This occurred in piecemeal fashion from 2019 through 2020. Although many of these look the same, I've just written case-by-case review. There's variation in the number of approvals that have been made in each province. A number of cases are being held back while waiting for more evidence to come up. Now, another issue that had come up is that some provinces had given the caveat that there needed to be some clinical monitoring that occurred in order to remain eligible for the treatment once it's approved. And Quebec had stated in their guidance that this monitoring should be annually, and Ontario and Saskatchewan had stated that every 4 months was their recommendation. Every 4 months may not be a completely arbitrary number, because that, of course, is the dosing interval for Nusinersen after its loading schedule. But of course, the clinical monitoring of Nusinersen is treatment and patients with SMA is a complex issue that I'll talk a little bit about. The first issue, of course, is that there's not really a clear consensus on the best scale, although there are some scales that are starting to appear again and again in the literature as being good tests for monitoring treatment response. As you can see from this paper in 2018, they provide a scale of different tests that can be used in the evaluation of adults with and children with SMA. But this is based on expert opinion. None of these have been tested head-to-head. A tricky issue with clinical monitoring is that it is very resource intensive in a number of different ways. You first of all require trained personnel in order to do most of these tests. The other practical issue is that you often require multiple personnel. So motor function tests may be done predominantly by physiotherapists, but respiratory tests such as peak cough flow might require respiratory therapists, for example. So it's quite a number of people who have to be together in one place for this monitoring to occur, or it may require multiple appointments. Which brings us to the issue of patient costs as well. Patients who may already have to come into hospital every 4 months for injections may then also have to come in for separate appointments for their clinical monitoring, which can increase costs to them if they require special transportation or if they live outside of larger urban centers. And of course, this produces costs to the system, which may not be accounted for when the government was funding this treatment. So for example, government decides that they will fund Nusinersen dependent on Q4 month screening, but the clinical monitoring requires availability of extra appointments, extra physician time, extra physiotherapist time, extra respiratory therapist time, and the funding for that may not have been provided and can put a strain on the system. So all of these things need to be accounted for. The sensitivity of the test is also a tricky issue. In this slide, which is familiar to you from the previous presentation, it demonstrates that there is a decline in this case, the HFMSE that occurs over time in all SMA types. On average, from this publication, this was estimated as being a decrease of 0.5 points per year. And as you may recall, what is considered a clinically significant reduction in the HFMSE scale is 3 points. So based on this, it would take your average patient around 6 years to deteriorate without treatment in a way that fits with the sensitivity of the scale. So that is an issue as well, which might argue pretty strongly against frequent monitoring. The reproducibility of these tests is also potentially an issue. There may be all kinds of reasons that there can be some fluctuation in the scores. From this publication, looking at the ULM score, for example, you can see that overall we're showing a trend toward improvement. But if you look at one data point to another, sometimes the score decreases from one interval to the next. That probably doesn't mean that the treatment didn't work for that time interval. It might relate to other factors that are difficult to control for. Maybe an individual wasn't feeling well on the day of their test, or maybe they'd recently had another illness. Maybe it was an early morning test and they had not had coffee yet. Maybe they're feeling anxious because of the pressure that they may not be able to stay on treatment if they don't perform well on the test. So there are a number of factors which could potentially contribute to fluctuations in this scale. Here from another publication where they give individualized patients data points. You can see, for example, on the red data points, there's quite a bit of fluctuation that occurs here. And if you were to evaluate the patient only twice and look at their progress from the 2nd month to the 6th month, you might say they had markedly deteriorated. But then you measure them again 4 months later, and you can see they're back up to where they were at 2 months. So hard to account for all of this. One thing that was reassuring in that study, though, is that the HFMSE, which is probably the most commonly used scale, seems to have very little variability to it, but still suffers from some of the same problems where there can actually be a decrease, where the patient may not have actually decreased. And the tricky aspect as well is what is the outcome that we are going for? And Dr. Hagenacker had spoken to this as well, that the outcome may not necessarily be to produce improvement for a slowly progressive disease, that perhaps maintaining stability is an excellent outcome in this case. Certainly in this recent paper by Dr. Hodgkinson and colleagues, they talked about some of the different scales and what are considered to be changes that are considered to be significant by patients and caregivers, and to what extent fluctuation may appear. So there's certainly a rationale on both sides here. There's reason to say that the frequency of monitoring should be lower for some of the above mentioned reasons. This is very resource intensive. This is a very slow disease course in patients who are stable in general. And there's this question of clinical significance, that if you want to achieve clinical significance with your monitoring, then you probably do need to look over a larger scale. But on the other hand, there are arguments that the monitoring should be done frequently. Some of the variation in the scores may not actually relate to the patient, but might relate to the rater or the person performing the test. Intra-rater variability being how likely the same person performing the test will give the same score every time that they see a particular finding. And then inter-rater variability being the likelihood that two different assessors are going to give the same score for the same finding. So we're all humans, and this introduces some of the error that can occur in these scales. Recently there was some expert discussion that occurred among colleagues in the Canadian Neuromuscular Disease Registry. This was headed by my colleague, Dr. Schellenberg in Saskatchewan, and on some discussion, we had recommended in this paper that clinical measurements probably are best done at baseline and at 6 months after starting treatment, and then at every 12 months thereafter. And it was thought that this probably reached the best balance of both managing the error that can occur with these tests, but also providing a long enough interval that treatment effects can actually be observed. And as far as what the best recommended rating scales are, most of the publications are at this point using the HFMSE and 6-minute walk test, and in patients who are ambulant, and in patients who are sitting, it will be HFMSE and RULM. But there is a paper in preparation by the same group that will give some more specific guidance on this as well, and hopefully be helpful to the community. So that's everything I was going to discuss on this today. Thank you very much for your attention, and happy to stay and answer questions if there's a question period at the end. Thank you.
Yes, thank you so much. Next, we have Catherine Boivin. Catherine received her master's degree in theater design from Concordia University in 2010. After a few years working as a freelance designer and illustrator in theater and live events, she took a full-time position working with 4U2C, which is an affiliate company of Cirque du Soleil. As a member of the creative team from 2014 to 2020, she worked on shows like Cirque du Soleil's Love, the Victoria's Secret's fashion show, and several pop artist music tours such as Celine Dion, Cher, and Bette Midler. She's also been involved with organizations like ours, MDC, and Cure SMA for 20 years. We're really grateful to have Catherine. We know we are in the last few moments, but Catherine will briefly be speaking about some key messages as an adult living with SMA, particularly in the province of Quebec, which Dr. Pfeffer highlighted is a little bit different in terms of access. Catherine, we don't hear you yet. There we go. Go ahead.
Yeah, sorry. Hi. Thank you for having me today. I'll try to be as brief as possible. So yeah, just a few key messages, I guess, to take away from both the two previous presentations, and also from my own experience as a 40-year-old living with SMA since since the 80s, basically. For sure, I've noticed a difference in terms of care going from pediatrics to adults. 20 years ago, probably was even more significant than it is today. 20 years ago, really the only continuance that I had from, going from the pediatric world to the adult world was really on my lung function. So, a pretty close follow-up on lung function and sleep function. But in terms of the rest of care, it was really lacking for a great amount of years, until a few years ago when I started being a bit more proactive in my own care, and also learning about the treatments that were upcoming. So I took it upon myself to reach out to specialists, and so I'm now happy with the team that I have around me, and lucky as well to be living in Quebec. and being able to access Spinraza, which I have started in December 2019, so not quite a year ago. As has been mentioned by the previous presentations, it's been a bit of a complicated road for me for Spinraza. I am one of those cases with a complex spine, with corrective spinal surgery that was done in the 80s. So it was difficult to find access to the spinal fluid. But thankfully, again, my team of neurologists are at the Neuro in Montreal, the Neurological Institute in Montreal, and they were able to find a way through radiology imaging to find a way to access my spine. And since then, I have been receiving Spinraza. Also, I have noticed, as has been mentioned as well, in terms of the clinical evaluation, you know, for adults with SMA in the context of treatment with Spinraza is definitely not adapted to my situation. The Hammersmith scale really doesn't apply to adults in my situation who are non-ambulatory, who have very limited function, but can still benefit from Spinraza, as I've experienced. So, you know, I've discussed this with my neurologist in terms of what kind of outcome measures could be implemented for adults that really speak to a more nuanced and a finer, you know, a more refined way of measuring the impact of the treatment. Obviously, it's difficult to measure stabilization. That's understandable. But I think there is still a way to do that, and we should find a way to do that. You know, in my case, for some specific examples in terms of head stability, I find that has been improved. But again, it was not measured as part of the outcome measures that are, you know, in effect currently, and that come from the pediatric trials and evaluations. So head stability is one of them for me. Also, fine motor skills like endurance in writing or endurance in lifting small utensils to feed. So different things like that, that I think could and should be tested to really represent, you know, have a broader representation of the kind of improvements that we can find in adult populations. I guess I'll leave it at that for now, unless there are other specific questions. I know we're already over time, so.
Thank you very much, Catherine. That was excellent, and it helps to validate some of the scientific findings that were shared earlier in the knowledge of the current state of treatments and of experiences here in Canada. This question here, I think we can go ahead and skip as it was answered, but it is about whether we have results on adults on risdiplam and Spinraza, and whether the combination of treatments is beneficial. And what we heard today is there aren't any studies available on the combination of these treatments yet. The next question is something very common that we hear at MDC. The person is asking about finding doctors with knowledge and experience with SMA. So they are wondering if there are any tips in terms of accessing help when working with a generalist doctor, both in primary care and specialists who are not familiar with SMA. Dr. Pfeffer, can you help to answer this question?
Yes, thank you. Yeah, I agree. This is challenging. SMA is a rare disease, and most of the experts who have familiarity with this condition will be in large urban centers. And of course, not everybody lives next to a university hospital. What I would say to this is certainly one of the positive things that has come out of our current circumstances is that virtual care is being delivered much more readily than it used to be. Certainly someone who may not otherwise have access to an expert in this condition might now much more easily have access using virtual means. Certainly, you know, myself being an urban doctor in Calgary, you know, always happy to do what I can with virtual care and try to avoid unnecessary travel.
Excellent, thank you. The next question here I think has also been well answered, but the individual commented that they felt nervous every time they had a functional assessment scheduled because it meant that it could mean that they lost access to the treatment. They felt that the tests and functional measures were appropriate for children and not adults, and they were wondering if there are any adult-specific measures. Dr. Pfeffer, I know you spoke about this, but any key message that you'd like to share with this person here who submitted this question?
Yes, I think the comment I would make is that I certainly sympathize with this. The testing is exactly that. It's a test. It's a way of us measuring particular functions and to try to quantify, you know, to get a number at the end of this. We all recognize, of course, that there may be other factors that aren't captured by the test. Now, as to adult-specific measures, I do believe that there is a rating scale that was specifically designed for adults, but it is correct that most of the SMA-specific scales were designed for pediatric patients. I think it is reassuring that for example, the HFMSE, which was showing these benefits in children with SMA and Nusinersen, we seem to be able to still measure that same kind of improvement in adult patients using this scale as well. So hopefully that is somewhat helpful.
The next two questions were ones that were submitted last week, and Dr. Oskwe did respond to them. After checking with Dr. Pfeffer, you agree with her responses, and I can refer you to that recording. But I wanted to take a moment to end today's webinar by thanking all of our speakers for their insights, and thank you to all of you for staying on the call after the 2 o'clock mark. Please feel free to email us at research@muscle.ca if you have any questions for our panelists. I'd also like to take this opportunity to thank Roche and Biogen for helping to support education initiatives like this and for their ongoing collaboration with MDC. And I wanted to use this opportunity to also invite you to a network meeting for adults with SMA this Thursday at 6:30, featuring guest speaker Jared Whalen, who will talk about his personal experience living with SMA, and also welcoming you all to register for next week's webinar on SMA and rehabilitation, which was highlighted today. Regardless of the treatment option, rehabilitation is key. Thank you again so much for your time and for joining us today. Have a great rest of your day and afternoon. Take care.